The issue is that we discussed jaundice several times in LFT, but now today I am going to give you some quick things and some technical things. Number one, what we should know, what is the normal serum bilirubin level, and we know that it is less than around 1.1 milligram per deciliter. And it is the, and if you define the jaundice, it is the yellow discoloration, or biochemically we say that increased level of the serum bilirubin more than 1 milligram %. If it is more than 1 milligram % in the blood, in the serum, then it is technically jaundice. It is not necessarily that, yes?
Consider normal.
No, more than 1 milligram. More than 1 milligram. Zyada than 1 milligram. 1 milligram is the range. 0.3 to 1 milligram is the range. Tamam? If it is, so that situation is called hyperbilirubinemia. Hyperbilirubinemia. But it doesn't mean that it should appear on the skin or it should be evident. Technically it is said that if it is more than 2 milligram, or very precisely if it is more than 3 milligram, then it appears on the body. So you see first in the sclera, and then you can see on the rest of the body, and then there is a yellow discoloration of the urine. So in combination of this, yellow discoloration of the urine, yellow sclera, body appearance, in addition to additional features, lethargy, uneasiness, loss of appetite, with the biochemical increased level of the bilirubin, the whole component is known as jaundice. The whole component is jaundice. But if I ask you what is biochemically hyperbilirubinemia more than 1 milligram is hyperbilirubinemia. How it is done? It can be done by 3 mechanisms. We can divide it anatomically: prehepatic, hepatic and posthepatic. We can divide it anatomically: prehepatic jaundice, hepatic jaundice, posthepatic jaundice. Prehepatic means something which is before the liver. Before the liver means involvement of the blood. So something which is related to the blood. What happened in the blood? You know that RBC has a specific life. After that specific life, the RBC get ruptured, and then when it is ruptured, so I will come to that later on, but so this is called hemolytic jaundice. Anything which is before the liver, anything that is before the liver, hemolytic jaundice. Which jaundice? Which jaundice? Yes? Hepatic? Hemolytic jaundice. So from the hemolysis of the RBC, lysis of the RBC precursor, ineffective erythropoiesis, or because of the ineffective erythropoiesis from the blood. Second one is the hepatic jaundice. Problem in the liver. Maybe viral, maybe bacterial, maybe trauma, maybe alcohol, whatever it is. Maybe alcohol, whatever it is, because of the liver, insult to the liver. So hepatocellular dysfunction in handling bilirubin uptake, metabolism and excretion of the bilirubin. And last but not the least is the post-hepatic jaundice. Obstructive jaundice. Obstructive jaundice can be because of two situations. One is intrahepatic, mana cholangioles have the problem. If you remember, we discussed last time that liver has three things going side by side. Number one, hepatocytes. Number two, hepatobiliary tract system, cholangioles, then bile duct, the common bile duct. And third one is the vascular system. So here there can be a problem inside, in small cholangioles, cholangitis is there, or some inflammation of the small ducts, biliary small ducts are there, or the extrahepatic obstruction. Mana it is nothing to do with the liver, but as it come out from the liver, maybe in the right hepatic duct, left hepatic duct, common hepatic duct, or when it combined with the cystic duct, maybe bile duct, common bile duct, or maybe because of downstairs there is a tumor, paraneoplastic syndrome, the tumor of the head of the pancreas, or some other stone. For example, the last case or today's case you would see, any situation that cause the stoppage of the flow of the bile, it can lead to a jaundice. That situation is called post-hepatic jaundice. Now if you are very smart and you have good brain, you can easily distinguish between these three kinds of the jaundice: pre-hepatic, hepatic and post-hepatic. Clear, guys? What are the clinical aspects? Clinically detectable if the serum bilirubin is more than 2 milligram. more than 2 milligram is on the lower side, but it is clearly evident when it is more than 3 milligram or around 3 milligram. With edema and dark skin, jaundice is masked sometimes. The people where they are with the dark skin or they have swollen legs. What is special about the sclera? Yes, because it has too much elastin, so it catch the bilirubin. Darkening of the urine, it is a very important situation, and you have different situation that gives you a dark urine. Yes, please.
The dark urine, is it because bilirubin or urobilin?
Urobilin. Urobilin. We'll come to the breakdown of that. But you should have many differential diagnosis. You have a differential diagnosis of dark. For example, if you don't take water the whole day, and in the evening, if you go to tamam, then you will be a dark urine. You will be a dark urine. Yeah. Or sometime you take multivitamin. Those they are going to gym, huh? They are taking multivitamin. If you take multivitamin, you will be a dark urine. Or sometimes some other medicine. If you take those medicine, you will be a dark. Even last year you took one of the course of respiratory, isn't it? Yes. And in the respiratory, I hope that you would have touched the tuberculosis, isn't it? Yes. And in tuberculosis, there are medicines. Which medicine causes this? Rifampicin. Rifampicin. If you take rifampicin, it will be dark. So there are so many situations where you have, yes please.
Dark yellow or dark black?
Dark yellow. Dark black is homogentic acid. Dark black is homogentic acid. Another alkaptonuria, there is another situation where, and that dark black urine is because that oxidize it. So whenever the baby passes urine, as soon as this urine come in contact with the oxygen, it becomes oxidized and it is black urine. Come on. So there are different situations. Yellow skin discussion, you have yellowish, you have it even in the vitamin A increase in carotene levels. Then mucosa, hard palate, again you can see the dark skin. Greenish hue skin of the sclera due to biliverdin indicating long standing jaundice, and generalized pruritus. Very important. It is a technical feature of the obstructive jaundice. Pruritus. You know what is pruritus? Itching. Itching all the time because of the bile salt. So duration of the jaundice, acute, maybe chronic, abdominal pain may be there versus painless jaundice. If there is an hepatitis, there may be an abdominal pain, arthralgia, rash, glands, pruritus, obstructive jaundice. Appetite, hepatocellular malignancies. Appetite is decreased, weight loss, malignancies. Colors of the stool. Color of the stool, if it is obstructive jaundice, then it will be, with obstructive jaundice, then what will happen? Bile will not go. When bile will not go, you will be having pale stool, chalk stool or peg stool. Hemolytic, you should see the family history if there is an hemolytic and the history of transfusion. And then you have very important for particularly the those they are on regular transfusions. For example, in hemolytic anemia or sickle cell anemia, in this type of the situation there. Just leave this. Intrauterine device and all this. Alcohol abuse, medications, INH, ethambutol, some anti-emetic drugs, they can also cause these type of the medication. Okay guys, colored urine. Bilirubin in urine due to jaundice, concentrated urine, dehydration, fluid deprivation syndromes, sulfasalazine used in ulcerative colitis. You took this, huh? Ulcerative colitis. Rifampicin, pyridine, and thiamine used in different medications. Porphyrias, just red urine, hemoglobin, myoglobin, urea, hematuria. All these give you the altered color of the urine or dark color of the urine. RBC, we know that RBC has a specific life, and once the RBC they are old, they are phagocytized. When they are phagocytized, they are lysed, and lysis occur extravascularly in reticular endothelial system, and subsequent the RBC is phagocytosed, intravascular hemolysis of the young RBCs, and this is due to because of the hemolytic disease. So what happened, and this is the hepatobiliary system, liver, right, left hepatic duct, then cystic duct, then common bile duct, and then it goes to the second part of the duodenum, and then so on. Now what happened to the RBC? If it is phagocytized, hemoglobin, globin is removed, heme is on the other side, Now this is the mushkila from here. This is the side. Once it is synthesized from the liver, this bilirubin is lipid soluble or water soluble? Huh?
Lipid.
From here, lipid soluble or water soluble?
Circulates down to the room. It's lipid soluble.
Doctor, I am in lecture actually. Assalamu alaikum. I am in lecture. So this is lipid soluble. When it is lipid soluble, it is very dangerous. It goes to the brain and lead to connectivitis. The body has a mechanism. That is the liver. Allah subhanahu wa ta'ala has created a specific enzyme in the liver that from and because it is dangerous, we know this, that we can't leave the dangerous thing free. We can't leave the dangerous thing free. So as it is dangerous, so albumin is one maskeen, he is doing everything and he will come and bind with this bilirubin. Now it is bind with the albumin, and then the albumin bring it to the liver, and in the liver when it reaches to the liver, you throw it in the liver. Now thank you very much, now you go to the liver. In the liver there is an enzyme system, and then it converted into so here in the heme oxygenase with the carbon monoxide and iron, biliverdin, that biliverdin reductase into bilirubin, then uridine glucuronide transferase, then bilirubin diglucuronide, and then excreted into stool or enter into the enterohepatic circulation. This is the mechanism, how heme oxygenase, biliverdin reductase and bilirubin. And then from here red blood cells, unconjugated bilirubin combined with the albumin, then bilirubin is uptaken, then conjugated bilirubin with the glucuronic acid. From the glucuronic acid it enters into the stool, urobilinogen, then urobilin is converted into stercobilin goes to the feces, and then this urobilin goes to the kidney, and then is converted into urobilin converted into urine. This gives you the stool color, this gives you the feces color. But if there is a blockage here, and DOD goes there, then we have pale color of the stool, That's why it is very much important that we should ask, when we are taking the history of this jaundice, we should ask the patient, do you have any change, have you found anything abnormal in your stool like this. Properties: normal serum fraction 90% unconjugated, 10% conjugated, so less. Water solubility 0, polar soluble, affinity for the lipids high, it is less, that's why connectivitis chances is high. Renal excretion is less. Yes, Hasoon? What is this? What is this? Renal excretion is, sometimes he is very brave, you know. Renal excretion is nil. It is why it is renal excretion is too much here and it is nil?
Because it's not lipid soluble.
What is your idea? Because this is water soluble and this is not water soluble. No, the answer, he is right, it's lipid soluble, but the answer is not this.
That's good, because it's not water soluble, it cannot go.
Yes, the answer is not this, that it is lipid soluble. My question is that why this is not appearing here and why it is appearing here. The answer is because that it is a lipid water soluble and it is not water soluble. Oh yes, you are right. And somebody is here, heart attack, acute myocardial infarction, and we gave him something, and then he goes. Wallahi, I wanted this, but actually I missed it. I wanted to give you streptokinase, but I gave you something else. I don't want that, I wanted that. Good. Vandenberg reaction is actually the reaction which gives you direct and indirect. Now this is pure biochemistry. I am not taking you into the pure biochemistry, but this is Vandenberg reaction. When it is positive, mean it gives you this is unconjugated, and here it is so this is the reaction. This is the reaction, Vandenberg reaction, which gives you the positivity and which tells you that this is direct bilirubin or the water soluble bilirubin, and this is lipid soluble bilirubin. Then temporary albumin binding is too much with this one, because why it is, because now point come here because it's lipid soluble, so that's why you want to keep it controlled, otherwise it will go to the brain. And then This is irreversible. Delta bilirubin is too much here. Yes, yes.
It is the transport carrier for the unconjugated.
Yeah, here. See here. This is here. Very limited type here, and then bring it here. Once it bring it here, it goes. It bring him like this in the door. It is like liver, huh? Throw it to the door. Now go inside. Thank you very much. I don't have to do anything with you because here is the mechanism inside the liver. Okay, guys. So bilirubin in the liver cell hepatocytes take up the unconjugated bilirubin, albumin, unconjugated bilirubin dissociate and unconjugated bilirubin into hepatic cells by the passive diffusion into hepatic cell ligand and bounding protein. Then insoluble unconjugated bilirubin is to be made soluble by the hepatocytes. Conjugation in the endoplasmic reticulum by the hepatocytes, formation of mono and diglucuronic acid with the monoglyceride and bilirubin monoglycuronate and diglucuronate. These are the steps. And actually these diglucuronate and monoglycuronate is what? If you remember our previous sessions, glucuronic acid, reaction with the carbohydrate, if you make yes, you have a point. If you make an acid of carbohydrate at carbon number 1, it will make a glucuronic acid. Tamam? So then this glucuronic acid is actually the conjugating component, and it converts the toxic into water soluble or less toxic. Then insoluble unconjugated bilirubin made water soluble for the excretion into the biliary caniculi, not caniculi, yes. Rate limiting step is in the metabolism of this one. Then common bile at 50% is not protein bound and no loss of albumin, and the remaining 50% is bilirubin, gamma bilirubin, and irreversibly bound. So that's how it is excreted, and then it goes to the gallbladder. From the gallbladder it enter into the so these are the 3 steps. Yes, please.
The excretion to biliary storage place is the rate limiting step.
Sorry, these are the ultimate steps. Sometime we have inflammation. Sorry,
there was in the liver, in the list of enzymes and the conjugation, there was one that is either deficient or dysfunctional.
Which one?
Transferase, I think.
Which one?
UDP.
Here?
The UDP transferase is the one that dysfunctions or is deficient sometimes.
For what?
I mean, one of the causes of that the liver cannot conjugate.
Neonatal jaundice, yes. There are 4 situations in neonatal jaundice. Porota syndrome, Gilbert syndrome, Dubin-Johnson syndrome. There are different syndromes. Yes, you are right. You are right. But that is in a neonatal jaundice. I am not covering the neonatal jaundice. I mean, if you go to the neonatal jaundice, it will be too much then. But we'll just quickly give you the. So common bile duct in the bile is excreted into the duodenum. Common bile 10% diffuses into the blood, and then this like conjugated bilirubin, and excreted and rest is not absorbed. Conversion of the conjugated bilirubin into uro and stercobilirubin. Urobilirubin excreted into stool, and part of urobilirubin enter into the enterohepatic circulation, and then from the gut, urobilirubin and not the conjugated bilirubin enter into the enterohepatic circulation, and then goes to the kidney, and from the kidney it is removed. And sometime, but if there is an obstruction, then reverse back and too much itching is there.
It is partially absorbed urobilirubin.
Yeah, very partly. Conjugated bilirubin is in the urine, is conjugated. Unconjugated bilirubin not filtered, not secreted, nil in the urine. Urobilirubin in the urine normally traces, but increase in the cholestasis. How you do this? You do this with the Vandenberg reactions. So there is a serum bilirubin, and then there is one reagent here, diazo reagent, and this compound, diazo compound, is formed, and then this diazo is as a color, chromogenic, it gives you a color. So reaction with the water medium, direct and conjugated bilirubin, reaction in ethanol medium, indirect or unconjugated bilirubin. Indirect includes the conjugated bilirubin and the unconjugated bilirubin. This is called total bilirubin. And then if it is react directly with this, you take sample, you put it there in the reagent, it gives you color directly. This is direct bilirubin, because that is water soluble. So you took water, put it there, give you color. But if it is insoluble in water, you took it here, you put that bilirubin here, because it's insoluble, it don't give you the color until unless you add ethanol in it. Why you are adding ethanol in it?
It has OH, hydroxyl group.
Ethanol, yes. What is your idea? Kya Mali Mudir? What is your idea about the ethanol? Why we add ethanol in it? There is a water, I have bilirubin in my hand, I put it here, gave you color, direct. Same bilirubin, same water, same bilirubin, I put it here, no color. But when I put ethanol in it, then it gives you reaction that gives you color. Reaction in the ethanol medium gives you color. Yes?
It's like
Solvent. Excellent. Ethanol, ether, benzene, chloroform, alcohol, all are the fat solvent. Okay, what are the features of the normal liver test? Not total bilirubin less than 1 milligram or around 1 milligram, conjugated bilirubin less than 0.15 milligram. What is then what is total bilirubin? This is the total bilirubin. Indirect includes common, the conjugated bilirubin, and then unconjugated bilirubin is equal to total bilirubin. So total bilirubin, then conjugated bilirubin, SGOT, we know that it's 31 international unit, almost sometimes the units are plus minus. SGPT, ALT less than 35 international, alkaline phosphatase less than 112 international unit. Gamma GT and 5 nucleotidase very much specifically, and these two tests, particularly this gamma GT, is a significant test in the liver diseases. So for example, you know that this alkaline phosphatase, it has so many other sources as well. For example, intestine, for example, placenta, for example, bones. You have so many other areas are there. So by any reason, if this is increased and you wanted to check whether it's coming from the liver or from other sources, you can check it by this one, gamma GT. Or similarly, if this is increased and you want to check whether something is wrong with the liver or not, you can cross check with this one. Urine bilirubin, normally it is absent. Urine urobilinogen in trace quantity, and urine bile salt, they are absent. So but that's why if somebody asks you which one is the simplest test to check so many things, that is the urine DR. So level of the jaundice, unconjugated bilirubinemia, prehepatic, this is intrahepatic or hepatic, then posthepatic. Unconjugated will be more in the prehepatic. In the hepatic it will be maybe normal, and posthepatic it may be normal. Conjugated bilirubin, here it will be normal, here it will be it will be more in case. AST, ALT may be normal, but here it will be problematic because the liver is involved. Alkaline phosphatase and gamma GT will be normal here, but it will be increased here in posthepatic jaundice. This is the simplest slide. Urine bilirubin is absent here, it is present here, and it will be more here in the posthepatic jaundice. Urobilinogen increase here, it will be present here, and it will be absent in the posthepatic jaundice. Tamam? Bilirubin conjugated level less than 0.1 to 1 milligram, total conjugated less than 0.2 milligram, alkaline phosphatate 25 to 112, aspartate aminotransferases and 5 to 31, alanine aminotransferase 5 to 35, albumin 3.5 to 5 milligram, and prothrombin time 12 to 16 milligram. What is the importance of these two? They assess the liver functions. Synthetic function of the liver. One of the OSCE slide might come in such a way that you may be having a question in the data session, and then we might ask you that if this is increased, which function of the liver has a defect. Tamam? We discussed in the LFT, we discussed so many functions of the liver. Maybe this one, maybe something else. Okay, utility of the liver function test. ALT, SGPT is less in alcoholisms. Albumin, assess severity of chronic liver disease. Alkaline phosphatase, cholestasis, hepatic or extrahepatic. AST and SGOT, early diagnosis of the liver disease, and it helps for the follow-up as well. Sorry?
Alcohol-related disease.
Yeah. Bilirubin, total conjugated, diagnosis for the jaundice. Gamma globulin, diagnosis for and follow-up for the chronic hepatitis and cirrhosis. Gamma GT, diagnostic for alcohol abuse and some of the toxicity of the medicines. Non-hepatic causes of abnormal LFT. LFT is there, but there are some abnormal is there. So abnormal LFT may be having some non-hepatic causes. For example, albumin may be less, protein losing enteropathies, nephrotic syndrome, malnutrition, congestive heart failure. You have problem. Alkaline phosphatase, bone disease, pregnancy, malignancy, advanced age, AST, myocardial infarction, MI, muscle problems, IM injections, bilirubin, hemolysis, sepsis, ineffective erythropoiesis, and PTT, or partial thromboplastin time, antibiotics, anticoagulants, steatorrhea. All these can give you abnormal LFT. And this is first time we are discussing this, okay? In last session, I think we have not discussed this, so this is very important. Now, how to approach the jaundice, how to clinically evaluate the patient, what are the differential diagnoses, what imaging medication will be used, for modalities will be, how to monitor the progress. So it's very simple, just see, estimate the serum bilirubin. If it is less than 1 milligram, normal. If it is more than 1 milligram, mushkila. See if it is unconjugated bilirubin, hemolytic jaundice. If it is conjugated bilirubin more than 20%, hepatocellular jaundice or maybe obstructive jaundice. Differentiate between hemolytic, obstructive jaundice. Hemolytic jaundice uncommon, but some hemolytic diseases like sickle cell anemia, thalassemia you have. So hemolytic disorders plus anemia, you can see that. Inherited spherocytosis, sickle cell anemia, G6PD, phenylketonuria, all these are. Acquired maybe some medication or proximal nocturnal hemoglobinuria we discussed last year in the house defense. In NBOD. Ineffective erythropoiesis, B12 deficiency, iron deficiency or folate deficiency. Drugs, rifampicin, probenecides, all these are the drugs that can cause the increased unconjugated or inherited Klinger-Nadal syndrome or Gilbert syndrome from the neonatal jaundice. If this is the conjugated serum bilirubin is increased, you will do the AST ALT to see the liver. Elevated AST ALT, you can check that, oh, there is something wrong with the liver. And then alkaline phosphatase, 5-nucleotidase, gamma GT will be normal if the liver is normal, or if there is a problem in the liver, they will be disturbed. Do alkaline phosphatase and gamma GT to confirm it whether it is obstructive jaundice or it has coming from the liver. So this is how you go further. If AST ALT is normal and then you have increase in the conjugated serum bilirubin and patient is coming with the itching as well, then something is wrong with obstruction, and then you can check for some other thing, ultrasound, you can do the ultrasound as well. Hepatocellular features in diagnostic conjugated serum bilirubin is increased, AST ALT is increased, alkaline phosphatase, 5-nucleotidase, gamma GT are normal. Hepatitis, you can check for hepatitis A, B, C, D, cytomegalovirus, Epstein-Barr virus. Toxic hepatitis because of the alcohol, malignancy, primary carcinoma of the liver or maybe paraneoplastic syndrome, C of the head, cirrhosis, liver disease, acute liver diseases or chronic liver disease. Imaging, you need 98% to 90% ultrasound helps you. If you do the ultrasound, it can give you structure, it can give you, because many of the things you can get from the structure. For example, if the normal structure is well organized, well defined, but if it is cirrhosis, it will be shrink. Tamam? So nodular structure. For gallbladder stone, yes, ultrasound can help you. X-ray help you, but sometime not. Sometime not. Why? Radiolucent. The PTC is the percutaneous transcholangiography. Tamam? You can go from the bile duct and then see the liver directly. Huh? Sorry?
They do drainage.
Yeah, they do drainage. ERCP, endoscopic retrograde cholangioplasty, something like that. You go from the retrograde, distal biliary obstruction, for the diagnosis as well as for the treatment. And MRCP, most useful for the duct stone. You go and remove the duct and then you bring the stone outside. Tamam? So these are all are these. Neonatal jaundice, I am not going to touch all these things, very common, but it's 50% healthy term infant, it occurs. Re-emergence of the kernicterus took place, and uterobilirubin is handled by the placenta and mother's livers. After the birth, neonate has to cope with the increased bilirubin production and immature liver cannot handle for this is for few days, but after that it is normal. So red blood cells, 3-hydroxy inhibitors from here. How you treat? You can treat with the phototherapy, you can treat with the exchange transfusion. Exchange transfusion mana, you take 50 ml of the blood of same. So you remove the 50 ml, you give the 50 ml. You remove the 50 ml, you give the 50 ml. So in this way,
The phototherapy is to make it water soluble, right?
yeah, phototherapy is. Then if very severe situation is this, you give him this hemoxygenase to block these steps. Very much severe, you can give this one, uridine glucuronide transferase. And then you can stop here as well. You can, sorry?
Hemoxygenation.
Sorry? Hemoxygenase will convert heme into bilirubin. Will convert into bilirubin. Because the liver is not functioning properly. Then you can stop this one, bilirubin reductase inhibitor, so the bilirubin will not be converted into bilirubin. Or from bilirubin to bilirubin diglucuronate, you can increase the conjugation. Or then last but not the least, excretion into the stool, decrease enterohepatic circulation, you can stop the enterohepatic circulation. By all these mechanisms, you wanted to decrease the bilirubin load to the blood.
These are
Yeah.
given
Like,
IV.
in that case, for example, biliverdin will accumulate. It will not cause toxicity or problem.
Yeah, technically it is less than this one.
If we give, for example, a biliverdin reductase inhibitor.
Yeah, so there will be too much
Too
bilirubin.
much biliverdin.
Too much bilirubin, but it will not convert into, it will not be as compared to the bilirubin.
These are given IV or
Sorry?
how are they given?
IV. But commonly, I'm not sure, but they help us. They help us. In serious situation, if it goes beyond that, then it can lead to problem. So basis of the phototherapy is not water soluble, unconjugated bilirubin is not water soluble in its form, so blue light or this conformation changes in the unconjugated bilirubin, and it is because of the photoisomer are water soluble, and blue light converts this unconjugated glucuronide into photoisomers, and then the soluble photoisomer pass through the glomerular filter and get excreted, thus the conjugation in the liver is bypassed directly at all. So here this is the post-hepatic obstructive jaundice, painful versus painless. Obstructive can be luminal stone, tamam, or stricture, maybe at the stricture, or maybe extra luminal because of the head of the pancreas. How you do? You can investigate by ultrasonography or by the by imaging techniques. Chronic liver diseases, we have alcohol liver disease, inherited conditions, chronic viral hepatitis B, C, autoimmune liver disease, autoimmune hepatitis, primary biliary cirrhosis, or maybe because of some disease like hemochromatosis, iron overload. Wilson disease? Wilson disease? Yes. Wilson disease? Yeah, which because of what? Wilson disease. Hemochromatosis because of what? Wilson disease? Wilson? Yes, Wilson. Wilson disease. Wilson disease. Wilson disease. Huh? Wilson. 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 Wilson? Copper overload. Alpha 1 antitrypsin deficiencies. Which other disease is associated with this? How are you? Good?
Which disease is linked with this?
Yes. Non-alcoholic go home and see. In the first year, the first year student, they are very smart, very intelligent, very smart. I was discussing with the glycolysis. In one of the steps, I said, why don't you ask this question from me, that why it is reversible, why it is not reversible. So one of the students sitting here, he said, okay, Prof, tell us why it is not reversible. I said, no, go home and read it. He went to another professor. And he said to him that, Prof, to Zahrani, he said to him, look, doctor, I went to Prof Salah and I asked him this question, but he said to me, he didn't give me the answer, so he said, no, go home and read it. He came to me that, Prof, what happened? I said, actually, I asked this question, that why you are not asking this question from me, that it is reversible, it is not reversible. Then in the return, he said, okay, tell us. I said, okay, go home and read it. So, non-alcoholic is like steatohepatitis, NASH syndrome, very important NASH syndrome. Budd-Chiari syndrome and cryptogenics, cholangitis, all these are the situation where there is a chronic liver disease, NASH. Now, some of the drugs which are hepatotoxic drugs, these are common drugs. Which one is drugs, by the way? Which one is this drug? Wallahi, Dr. Waleed al-Shaka will jump from the 5th floor. Paracetamol, tamam. But all these drugs, some of them you know, some of them you might not know. You should know this one: losartan, labetalol, diphenhydramine, isoniazid. This is anti-fungal like things. Amadron, you should know because of the heart. We discussed this. So some of the drugs you know them, and niacin, vitamins, you know these things. They are also causes the liver jaundice. And the cholecystitis, gallbladder wall is thickened, so you can see in the, this is the gallbladder wall, and you can see the thick gallbladder wall in ultrasonography. Causes of the cholestatic jaundice: you get acute liver injury, viral hepatitis, cholelithiasis, alcohol hepatitis, stone obstructing the colon bile duct, chronic liver injury, biliary strictures, autoimmune cholangiopathies, cholangiocarcinomas, drug, total parenteral nutrition, pancreatic carcinomas, systemic infections. You know, I mean, these are the intrahepatic, these are the extrahepatic problems where you can have the causes of the cholestasis. Too much cholesterol, the bile is accumulated there. Drug causing cholestasis: anabolic steroids, testosterone, antithyroid agent, methimazole, azathioprine, immunosuppressive agent, and chlorpromazine, largectil, anti-allergic, clofibrate, anti-lipids, oral contraceptives, and then oral hypoglycemic drugs. These all are lead to cholestasis, the stasis of the bile duct. So here, this is the situation. What is the situation here? Huh? Ascites, ascites. Why it is there here? Why they put a patch here? Drainage. Good. Portal hypertension, varices, ascites, hypersplenism, synthetic dysfunction, coagulopathy, encephalopathies, and immunodeficiency, malnutrition, hepatocellular carcinoma. These are the complications of the coronary liver disease. I am not going into the detail of this, but causes of the jaundice and frequency, you will go home and read it, okay? So, when referred to a general specialist, gastrointestinal specialist, when you have no idea, unexplained jaundice, suspected biliary obstruction, acute hepatitis or severe or fulminant hepatitis, unexplained abnormal liver function test, unexplained cholestasis, cirrhosis, non-alcoholic for considering liver transplant, you will refer this gentleman to the one of your colleague. Suspected of liver disease, Wilson, or chronic hepatitis, you will refer this to the specific gastroenterologist. Don't treat him by yourself, otherwise it will be mushkila. So, jaundice and liver injuries are very common. Careful history and physical examination are must. Acute hepatocellular disease with the jaundice, chronic hepatocellular disease, chronic liver disease, cholestasis and obstructive jaundice with these problems, ultrasonography, and then retrograde cholangiographies, ERCP, MRCP, and PTC help us in the diagnosis. Laparoscopy and liver biopsy, very helpful. Treatment as per the cause, and if you are not expert, send him to one of your colleague. Don't treat him ala tula. Tamam? Thank you very much.